Welcome to 12 Lead EKG Acquisition and Interpretation Part 4, STEMI. So here it is. You've all been waiting for it. The big event. Determining STEMI, ST elevation myocardial infarction. These are the STEMI criteria for males and females. Note the new onset left bundle branch block, which is also inclusive of STEMI criteria. You notice that they talk about contiguous leads. So we are revisiting this again because it is very important. What is a contiguous lead? If there's one thing that healthcare providers and healthcare provider students are great at, it's developing memory aids to get them to remember all this information that they have to store in their brains. This is a contiguous lead chart, and it shows which leads are contiguous leads. And you need to remember that whenever you're faced with ST elevation, there needs to be at least 2 or more contiguous leads affected for that to be a STEMI. So if you only have elevation in lateral lead 1 and no elevation in AVL, V5, and V6, that doesn't meet STEMI criteria. Now, that does not mean your patient is not sick. It does not mean that the patient does not have to go to the hospital. It does not mean your patient is not having a heart attack. It simply means that it doesn't fall under that criteria. One additional memory aid that somebody told me years ago is about a little lie named Sal. Liillissall. For lateral, inferior, inferior, lateral, inferior, septal, septal, anterior, anterior, lateral, lateral. I hope this helps. Just remember, understanding is far more powerful than memorization. Contiguous leads can be a little bit difficult to be understood and explained. So let's start with 2-3 and AVF. In lead 2, the camera view of the electrical triangle is down on the left leg, looking upward towards the right shoulder. In lead 3, the camera is closest to the right leg, looking upward towards the left shoulder. And in AVF, the camera is on the ground, looking upward towards the inferior portion of the heart. Note that all the cameras are facing upward, looking at approximately the same portion of the heart. Let's talk more about contiguous leads, and specifically in leads 1, AVL, V5, and V6. It's all about where we perceive the camera to be. So in lead 1, the camera is perceived to be at the left side of the patient, looking over the shoulder towards the right arm. And it measures the electrical pathway from the right arm to the left arm, negative to positive. In AVL, the perceived camera is on the left side of the patient, looking in at the left side of the heart, lateral wall of the heart. In V5, the camera, specifically the electrode, is just anterior to V6, which is at the axillary line. And of course, we have V6 at the axillary line, looking at the lateral portion. So all these perceived camera views are coming in from the left side of the patient, looking at the lateral portion of the heart. That's why they are all considered contiguous. In section 10, we're going to discuss ST elevation MI criteria and go over some interpretation of some 12 lead EKGs, including some STEMIs and other medical conditions. If you were to walk into a hospital, an emergency department, and say to a provider, I have a 3 lead and it looks like they are having a STEMI, these are probably some of the faces you may get from providers that realize that you cannot interpret or diagnose a STEMI in a 3 lead. And this will be the face of the provider that knows better. So why can't you just print out a 3 lead or look at the telemetry monitor and make a determination a patient is having a STEMI? The answer is the high-pass filters that are utilized to create the image in a 3-lead that actually causes artifact in a 12-lead. And once you select the 12-lead option, the monitor utilizes different filtration to come up with your image on the 12-lead EKG. If you have selected the 12-lead EKG function on your cardiac monitor, and the cardiac monitor prints out a copy of the EKG, and it reads, meets ST elevation MI criteria, there is a very high likelihood that this person is experiencing a STEMI. You should alert the receiving facility, and you should send them a copy via telemetry. You may recognize this slide from part 3. It is very important that you understand where you're measuring from when you're looking for ST elevation and ST depression. So let's just go through this again. Finding the J point. The J point is the portion of the EKG that separates from the QRS. You can find it by moving up over the P wave, QRS, or the RS in this situation. And at the point where the ST segment branches off from the QRS, that is your J point. If you need to, you can go from right to left, up and over the T wave, and back to the point where the ST segment separates from the QRS. So we understand that we measure the J point to determine if it is elevated or depressed. But elevated or depressed from what? What is that line? If we expand this a little bit, you will see a white line. That line is created by taking the TP segment from one complex to the next and to the next and drawing a straight line across. I will highlight the TP segments in yellow so you have a better understanding. When attempting to determine if there is ST depression or ST elevation, it is best to A. Find the M point, create a line from QRS to QRS. B. Find the Q wave, create a line from P wave to P wave. C. Find the J point, create a line from TP segment to TP segment. D. Find the J point, create a line from PR segment to PR segment. If you answered C, find the J point, create a line from TP segment to TP segment, you are correct. The inferior STEMI is recognized on a 12-lead with ST segment elevation in leads 2, 3, and AVF. You may see reciprocal ST segment depression in the high lateral leads, 1 and AVL, or the lateral leads V5 and V6. The inferior portion of the heart is supplied with blood from the right coronary artery via the posterior descending artery in about 80% of the population. In the other 20%, it's supplied with blood via the circumflex artery, which branches to the posterior descending artery. The right coronary artery also supplies the AV node, so a blockage may create bradycardia, heart blocks, and arrhythmias. Up to 40% of inferior STEMI have right ventricular involvement, so providers should consider obtaining a right-sided 12-lead EKG, or V4R, and consider obtaining a posterior 12-lead EKG in these patients. Obtaining a V4R view is very easy. You will find the electrode and wire at the V4 position, which is the fifth intercostal space at the midclavicular line on the patient's left side. You will take that lead off of the electrode and leave the electrode where it sits, as you may have to reconnect it to monitor the regular 12 lead. You will put a new electrode on the wire and attach that electrode to the fifth intercostal space, mid-clavicular line, on the patient's right side. You have now created V4R. Obtain your 12-lead EKG and mark it with V4R in big letters to avoid any confusion. Recognizing the posterior STEMI is almost like opposite day. If you notice ST segment depression in leads V1 through V4, it's quite possible that the opposite view, which is the posterior, could have elevation. So you want to perform a posterior when you see V1 through V4 depressed. Also, you want to maintain a high index of suspicion in an inferior and an inferior lateral STEMI. The reason is those areas that are supplied with blood in the posterior region also drop off blood to the areas such as the inferior and the lateral wall. So understand that it's a big highway that delivers blood to these areas, and it depends where the highway is blocked as to what terminal ends will be affected. To obtain a posterior view with leads V7, V8, V9, remove the wires from V4, V5, V6. Leave the electrodes stuck to the patient in those locations. Apply new electrodes to the end of the wires you've removed and apply them in order V7, V8, and V9. So use the V4 lead for V7, the V5 lead for V8, and the V6 lead for V9. Once you obtain your 12 lead, mark V4, V5, and V6 with a legible mark, V7, V8, and V9 respectively. That way, providers down the line know that that was not an original 12 lead, and that is a posterior view. That's very important. Once you have obtained your V7, V8, V9 view, it's as simple as just looking to see if there's elevation or depression. Please note on this picture, they have crossed out V4, V5, V6, and written in large letters V7, V8, and V9. There's nothing worse than showing up to an emergency department with 4 or 5 12-lead EKGs, and you've done everything that you were supposed to do, and you've done your right-sided or you've done your posterior 12 leads, and you can't determine which is which. So as soon as that comes out of the monitor, you need to be on top of that with a Sharpie or a black pen and write that in large letters so it's distinguishable from the other 12 leads. The posterior portion of the heart is provided with blood via the right coronary artery. That supplies the posterior descending artery, which supplies the posterior circulation in 70% of patients. In 10% of patients, posterior descending artery originates from the left circumflex, and the remainder of patients, the RCA and left circumflex both supply the posterior descending artery. Clinical concerns really have to do with the provider being vigilant for posterior STEMI by viewing the septal and anterior leads and giving consideration whenever there is an inferior or inferior lateral STEMI evolving in front of them. Recognition of a septal or anterior wall STEMI is a little bit more complicated than most other STEMIs. As you will see in upcoming slides, it has to do with the way that the septal and anterior wall are supplied with blood. It is unusual that you're just going to get a septal or just an anterior wall STEMI. Usually they occur in conjunction with one another because of the way the blood is supplied to that portion of the heart. Blood is supplied to the septal and anterior portion of the heart by the left anterior descending and the 6 branches called septal perforating arteries that supply the anterior 2/3 of the anterior septum. Other branches called diagonal branches supply the anterolateral wall of the left ventricle. If the occlusion of the left anterior descending artery occurs high enough in the septum to inhibit circulation to the septal wall, you may notice interventricular conduction disturbances such as bundle branch blocks. Keep in mind, a new onset left bundle branch block is inclusive for STEMI criteria. Also recognize that a septal and anterior wall STEMI is usually not one or the other, but a combination of both. This is due to the coronary arteries that supply the area with blood. The left anterior descending artery is a very large artery that supplies portions of the heart with blood. So occlusion at any point in that artery is going to affect several areas. An EKG is inclusive for STEMI criteria if the ST elevation is present in AVR greater than or equal to 1 millimeter. ST elevation in AVR is greater than or equal to that of V1, and widespread horizontal ST depression. This will be most prominent in leads 1, 2, V4 through V6. So do we have that? We have elevation greater than 1 millimeter, AVR. We have elevation that is greater than V1 in AVR. And we have widespread horizontal ST depression. And it does appear to be more prominent in 1, 2, V4, V5, and V6, although it is also present in AVF and V3. Elevation in AVR could indicate one of 3 things: proximal left anterior descending artery occlusion, severe triple vessel disease, including the right coronary artery, left anterior descending artery, and the left circumflex artery, or diffuse subendocardial ischemia, and this could be due to an oxygen supply demand mismatch, maybe following resuscitation. Let's take a look at this 12 lead. We see marked elevation in V2, V3, V4, V5, V6, 1, and AVL. So we're dealing with an anterior lateral STEMI. V2 is elevated, so there's septal extension or septal involvement. We spoke earlier in the presentation about reciprocal changes, and I want you to take note of lead 3, which is an inferior lead, and you can see this depression in at least one of the inferior leads. So that stems from and speaks to reciprocal changes. You have elevation in 1, AVL, V5, and V6, which is your high lateral and lateral leads. Therefore, it would stand to reason you would have reciprocal changes in the inferior leads as an offset to that. This would be a very sick patient. An anterior wall STEMI is sometimes called the widowmaker, and that is because of the blockage in the left anterior descending artery, which is a very large turnpike that supplies a large portion of the lower part of the heart with blood, including the anterolateral portion and the left ventricle. This is a true emergency, and this person needs a cardiac cath lab right away. Let's see what we can do about interpreting this 12-lead EKG. Lead 1, no elevation of depression. Lead 2, marked elevation. Lead 3, marked elevation. AVR, depression. AVL, depression. AVF, marked elevation. V1, V2, V3, V4, depression. V5, could be argued there's a little bit of elevation. And V6 is elevation. It seems that 2, 3, and AVF are elevated. we are dealing at least with an inferior wall MI. V6 is definitely elevated, but V5 doesn't appear to be elevated, nor does 1 or AVL. So it's not inclusive for the two contiguous lead criteria necessary to diagnose a STEMI. AVR is depressed, as is AVL, which could be a sign of reciprocal changes for this inferior wall MI. V1, V2, V3, and V4 are all depressed. At this moment, we're dealing with an inferior wall MI. So we're going to recognize that the bottom three leads are continuous leads, and that's the way this particular facility has their 12 lead EKG set up. I'm going to cover those over so as to not confuse you. So it looks like elevation in lead 1, elevation in lead 2, depression in lead 3, depression in AVR, elevation in AVL, elevation in V2, V3, V4, V5, and V6. So leads 1, AVL, V3, V4, V5, and V6 all have elevation. So at minimum, you're looking at an anterior lateral MI. There is elevation in lead 2. However, there is not more than 2 contiguous leads that are affected in the inferior portion. So it would have to be 2 or more contiguous leads in 2, 3, and AVF, and there are not. V2 is elevated, but again, it doesn't fit the 2 or more contiguous leads as V1 is not elevated. And AVR is depressed. So if we look at our chart, leads 1, AVL, V5, and V6 are elevated. That's the lateral wall STEMI. V3 and V4 is also elevated. So that's the anterior portion involved as well. So you would reflect this as an anterior lateral MI. Look at AVR. AVR is depressed. AVR looks from the right side of the heart. So you could consider that in V1 being depressed as reciprocal changes to the lateral leads that are elevated, the opposite view. You are called to the residence of a 60-year-old male. He complains of chest pain, which is atraumatic. 8 out of 10, it's sharp, radiates to his jaw. It worsens when he lays down and improves when he sits up. He doesn't have any shortness of breath, nausea, dizziness, or weakness. He states that he smokes 1 pack a day, doesn't consume drugs, and he consumes alcohol from time to time socially. Nothing in the recent past. You are called to the residence of a 60-year-old male. He complains of chest pain, which is atraumatic. 8 out of 10, it's sharp, radiates to his jaw. It worsens when he lays down and improves when he sits up. He doesn't have any shortness of breath, nausea, dizziness, or weakness. He states that he smokes 1 pack a day, doesn't consume drugs, and he consumes alcohol from time to time socially. Nothing in the recent past. Vital signs are as follows. He has a pulse of 120 beats per minute. It's regular and strong. Respirations are 16 regular and non-labored. His blood pressure is 122/78, measured by NIBP. He has an SpO2 of 99% on room air. His untitled CO2 is 38 millimeters of mercury. His body temperature is 99.3 measured orally, and his blood glucose is 185 milligrams per deciliter. To the right is his 12-lead EKG. Let's see what we can do about interpreting this 12-lead EKG. Remember, we're measuring from the TP to the TP, not the PR to PR. Lead 1 looks pretty good. Lead 2 looks like it has ST elevation and some PR depression. Lead 3 looks like ST elevation. AVR looks like ST depression. AVL looks good. AVF looks like ST elevation. There is ST depression with flipped T waves in V1 and flipped T waves in V2. V3 has elevation, like V4, V5, and V6 all have ST elevation. But look at the morphology of the T waves in the ST segment. There are concave and convex ST segment morphologies, and they are indicative of two different processes. So let's look about interpreting this 12 lead. Continuing on. The diffuse concave upward ST elevation, yes, that is true. ST segment depression in AVR, that is also true. There's PR segment depression, as best demonstrated in leads 2 and V3. Well, we definitely have it in 2. And if you look very closely at V3, you can see that although there's ST elevation, the PR interval is also depressed. And there's a lack of reciprocal ST segment changes. This is an important feature in differentiating acute pericarditis from acute myocardial infarction. I would, however, like to stress, if a patient has chest pain, you need to treat the patient per protocol and include these other differential diagnoses, as a patient could have both or two or more differential diagnoses, including NMI. So pericarditis is broken up into 4 stages based on the length of time the person has been experiencing pericarditis. Generally, stage 1 occurs during the first 2 weeks and includes widespread ST elevation and PR depression with reciprocal changes in AVR. Stage 2 occurs during 1 to 3 weeks and includes normalization of ST changes, generalized T-wave flattening. Stage 3 occurs 3 to several weeks on, includes flattening of the T waves, and they become inverted. And stage 4 includes EKG returning to normal, which is several weeks onward from onset of symptoms or diagnosis. It is interesting, however, that the EMS provider does not know what stage a person may be in unless they have told them that they have just recently been diagnosed with pericarditis and when the symptoms started. So you need to be mindful of all EKG changes which may not appear normal and clue you into an issue that may be occurring with the cardiac system. Causes of pericarditis include infectious causes, immunological, uremia, post-myocardial infarct or Dressler syndrome, trauma, following cardiac surgery or post-pericardiotomy syndrome, paraneoplastic syndromes, drug-induced syndromes, and post-radiotherapy syndromes. You are called to the residence of a 28-year-old female. She reports sudden onset, shortness of breath, and is tachypneic, which means she's breathing fast. She does not have chest pain or any other pain, but she is unable to catch her breath. Does the patient smoke? Yes. Does the patient consume drugs? No. Does the patient consume alcohol? No. The patient's vital signs are as follows. She has a pulse of 112, it's regular and strong. Respirations are approximately 22, regular. Her blood pressure is 139/70, measured by NABP. Her SpO2 is 99% on Ramier. Her untitled CO2 is 24 millimeters of mercury. Her body temperature measured orally is 97.3 degrees Fahrenheit, and her blood glucose is 104 milligrams per deciliter. What are some of your differential diagnoses for this patient? You have applied a 12-lead EKG. She's showing S waves in lead 1, Q waves in lead 3, and inverted T waves in lead 3. This is consistent with an S1, Q3, T3 pattern. This is indicative of a possible impending pulmonary embolism. Once at an emergency department, the patient may get some laboratory testing, including a D-dimer test. They may send the patient a CT and get a CAT scan with or without contrast of their lungs. This is an image of a CAT scan of a patient who has a saddle PE. Any occlusion of the pulmonary vasculature mitigates the body's ability to exchange oxygen and carbon dioxide and can prove fatal. So your ability as a provider take the subjective data, objective data such as vital signs and other values you may obtain, and interpret the 12 lead properly, may create a positive outcome for your patient. The last 12 lead presentation we're going to go over in this presentation is Wolff-Parkinson-White syndrome and how to recognize it, and more importantly, how to treat it. Wolff-Parkinson-White syndrome rolls in all of what we have learned on all four parts of this presentation. WPW is recognized by looking at a 12 lead EKG and realizing that it has a PR interval less than 120 milliseconds, has a delta wave, a QRS greater than 110 milliseconds, and an ST segment and T wave discordant changes. And remember, discordant changes mean the total sum of the QRS is traveling in an opposite direction as the total sum of the T wave. PR interval would be less than 120 milliseconds. If you recall from previous parts of the presentation, left to right on the EKG represents time. This yellow block represents 0.12 or 120 milliseconds. This blue block is about the duration of the PR segment. A shortened PR segment should indicate to you that it is taking less time than is normal for a signal to get from the sinoatrial node down into the AV node or into the ventricles. There is a dull upslope of the QRS. It's known as the delta wave. This is because the re-entry into the ventricles is caused through the bundle of Kent and not through the normal conduction pathway. I have illustrated some of the delta waves on this 12 lead. The QRS would be greater than 110 milliseconds. Remember, left to right on the EKG is time. I have set arrows delineating the beginning and end of this QRS complex. As you can see, it is greater than 3 small boxes, which would be 120 milliseconds. You would notice ST segment and T wave discordant changes. Well, here they are, V1 and V2. The QRS and the T wave appear to be traveling in opposite directions. In normal conduction, the sinoatrial node fires and the impulse travels through internodal pathways. They approach the atrioventricular node and the impulses are slowed down. It goes through the bundle of his, into the left and right bundles, then to the Purkinje fibers where it innervates the ventricles. In Wolff-Parkinson-White, there is an alternate pathway that is created. It is called the bundle of Kent. And the signal travels from the sinoatrial node and goes through the bundle of Kent as opposed to going through the AV node. This can cause a rapid tachydysrhythmia because the AV node is responsible for slowing down the impulses, especially true in atrial fibrillation with rapid ventricular response. Because as you know, with atrial fibrillation, you may have an atrial rate of 100 or 200 beats per minute, but the AV node is only allowing, hopefully, 60 to 100 beats through to innervate the ventricles. The second issue that could happen in Wolff-Parkinson-White syndrome is there could be a reentry. The other major issue that can occur as a result of Wolff-Parkinson-White syndrome is a reentry phenomenon, where the Purkinje fibers actually make contact with the bundle of kin, and there's a bridge between the Purkinje fibers and the bundle of kin, creating a reentry. And that pulse or impulse reenters from the Purkinje fibers to the bundle of kin, back to the sinoatrial node, and then that signal is just sent right back through the same pathway. If you can imagine the old style merry-go-rounds where the faster they spun you, the more momentum you picked up, that is what you're dealing with here, and that can cause tachydysrhythmias. When dealing with a patient who says they have Wolff-Parkinson-White, or you've identified Wolff-Parkinson-White on the 12 lead, and they are in atrial fibrillation with rapid ventricular response, it is important that you understand that there's the bundle of kin, and impulses probably are not going to go through the atrioventricular node as they should and be slowed down. They're going to go directly to the bundle of kin, and you could end up with an actual link between the Purkinje fibers and the bundle of kin and have a reentry. So in the case of somebody who has atrial fibrillation with rapid ventricular response and WPW syndrome, you do not want to administer diltiazem. Diltiazem administration could lead to one of a couple things. It could make the heart go faster, or it could trigger ventricular fibrillation and make their heartbeat stop, and then they're in cardiac arrest. Instead, you should give amiodarone or procainamide. If you ever have a question, contact Online Medical Control. But this is just for somebody with WPW and atrial fibrillation with a rapid ventricular response or a tachydysrhythmia. You are an ALS provider who has intercepted with a BLS team. The BLS providers obtained a 12-lead EKG, and you noticed an inferior STEMI. It is likely the ST segment in two or more of which leads are elevated. A, 1, 2, 3, V1. B, 1, AVL, V5, V6. C, 1, and AVL only. D, 2, 3, AVF. You answered 2, 3, and AVF. You are correct. You have obtained a 12-lead EKG and you notice a lateral STEMI. It is likely that the ST segment in two or more of which leads are elevated. A, 1, 2, 3, V1. B, 1, AVL, V5, V6. C, 1, and AVL only. D, 2, 3, AVF. If you have answered 1, AVL, V5, V6, you are correct. Consider again the camera angles in those leads. They are all from the left side of the body. They all look at the left lateral portion of the heart. Due to the coronary arteries, which supply these areas of the heart with blood, it is not common for patients to experience a STEMI in just one of these regions. However, elevation in V1 and V2, V3 and V4, V5 and V6 are inclusive for which types of STEMI? A, V1 and V2, septal. B, V3 and V4, anterior. C, V5 and V6 lateral. D, none of the above are accurate. E, all of the above are accurate. If you chose E, all of the above are accurate, you are correct. V1 and V2 look at the septal wall. V3 and V4 look at the anterior wall. V5 and V6 look at the lateral wall. Some use the mnemonic SAL to recall this. We hope that you've gleaned some value from our presentation. Please remember, it is important that you follow all of your local and state policies, procedures, protocols, online and offline medical direction.